Good morning. It's Wednesday, December the 29th. This is Open Mics with me, Dr. Stephen Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you for the Doll Simons Family Studio. Thank you for joining us. Follow us also on YouTube, Facebook, and others. COVID cases are going up here in the metro, and a recent stat published in the Los Angeles Times finds 1 in 100 adults age 65 or older has now died from COVID-19. That is a staggering thing to say out loud to somebody who's practiced in medicine for 35 years. A number that this number is some wondering what more can be done to protect our older population, especially those in nursing and assisted care centers. So make sure to get your questions sent to us on YouTube, Facebook, and the Medical News Network. You find links to those right here on your screen. But first, Dr. Hawk, and we're going to have a little conversation about some of the stuff going on out there.
Yeah.
How are numbers today?
Yeah, not good.
They aren't good.
I think I was a little bit happier yesterday. We had seen a little bit of a decrease in our total active infections. I think we had gone down to 59 at one point, just in that high 50s. We're up to 69 active infections right now, 13 in the ICU, but 12 of those on the ventilator. That is really critical illness for that majority of patients that need to go to the ICU, need that upper level of care. Of those 69 active infections, only 5 are fully vaccinated. So really what we have seen, Steve, the last couple weeks is that our fully vaccinated population in the hospital has been in that 3 to 5 to 7% range. Obviously earlier when we were going through these numbers, we'd had up to 15% that were vaccinated. But again, we were getting in patients from other places. We know that those patients had significant comorbidities. They had not yet had their boosters. So overall, it continues to be a very low percentage or amount of people who are fully vaccinated coming to the hospital needing that care. And then we still have also 29 additional patients meeting that recovery period. So our total for actives and in recovery is 98.
That's a high total, and it starts to feel like November of 2020 all over again. We're going to look at a couple of slides momentarily. I just want to point out a few things that we're seeing across the country, and this is data coming out of the New York Times. This is the rapid rate of increase you can see in states. This is a number of newly reported cases. This graph was published on Monday. You can see how rapid the spike is in COVID-19 new diagnoses throughout all these states. And then if you look at the national graph, look at this trend about what's going on and compare it back to the November of 2020, and you can see we are steeper than at any point throughout this crisis. The other thing that's important to remember is that the CDC said about 2 weeks ago that it was about 73% of the cases were Omicron. They revised that numbers down yesterday to say, well, it's probably 53% Omicron. That means it's 47% Delta. And in our area, it may be between 15 and 45% Omicron in the Kansas City Metroplex. Across the state of Missouri, it's about 53% Omicron, but we're probably lower than that because St. Louis is a little higher. And joining us today is Dr. Rachel Leisman, the director of the Microbiology Lab. She and I were just talking a little bit about that. Dr. Jessica Calendar-Rich, one of our outstanding general geriatrics physicians today. Also look at that next slide. Not only are the cases rising, but that risk level slide. You guys, the next one after that. These are the risk levels. Look at the purple on that map and look at where we live. Folks, we're right smack in the highest risk zone in the United States. And if you remember a few weeks ago when we showed that it was concentrated more in the Northeast, a little bit in the southern Mountain West. But now it's really engulfing the entire Midwest. Look at the tip of Florida. It's lighting up now. It's in the tip of California. So the map is turning to one of the highest, worst maps we've seen in a long time. Why is that? Well, Omicron is incredibly transmissible, but Delta is also still very transmissible. I've heard some people say, well, oh my gosh, it's just a cold. Oh, my cold. Well, no, oh my crying out loud, it is not just a cold, and that's really one of our struggles. So we're going to go deeply into that conversation in just a moment, but first let's see if there's any questions from reporters.
Hi guys, good morning, it's Taylor at 41.
Hey Taylor.
I wanted to check with you about that, something you just said there about, it being just a cold. Many more employers are now going back to the please don't come to work if you have any kind of symptoms. But obviously, there are people that have job situations where that's not an option for them. They have to go to work for one reason or another, whether it be their own personal or kids or whatever it is, and staying at home unless it's absolutely necessary is just not an option. Can you give me a renewed sense or an up-to-date sense with Omicron, especially about symptoms that should absolutely make you stay at home versus what you need to do if I wake up and I've got a sniffle or a little bit of a sore throat, but I don't feel all that bad? What's the best practices for people that are really have to go to work situation?
Taylor, that is the big question of the moment, I think, because I'll tell you, right here in healthcare, we have significant staffing shortages throughout healthcare. You're seeing people canceling cases left and right, canceling clinics because they can't staff the practices, they can't staff the operating rooms, we can't staff inpatient beds. And we had our chief medical officer call yesterday, and I'll tell you, it was tough. It was one of the toughest calls we've had. There was just this note of resignation, and I think that it's what you hear throughout the United States, which is that healthcare workers are affected by this, and we don't have enough staff, and people are having to close down things. We probably have, I'm going to forecast a little bit that throughout our metroplex and throughout our country, we're going to see more cases, more elective surgeries being canceled than at any point in the pandemic, not only because we have a lot of patients in the hospital with COVID-19 and a lot of patients in the hospital with everything, but because we don't have enough staff because so many people are sick. So when people say Omicron is just a cold, no, it's not. It's a cold that can make you really ill, and even though hospitalization rates with Omicron are probably 40 to 60% less than Delta, again, that's South African. Oh boy, now we're got somebody drilling here. They're drilling this into our heads about the danger of Omicron. So even though with Omicron, hospitalizations may be 40 to 60% less, the reality is that that's data based from South Africa, Europe, and some early American data. What we also know is that we're not sure what's going to the impact on the elderly going to be. We're not sure about the infirmed, and we're not even sure about kids because we're seeing a spike with Omicron hospitalization in children. All that means that when people think they just have a cold, Hawkeye, I'm not sure we can say they just have a cold. So let's talk a little bit about the symptoms of Omicron that distinguish it from the common cold.
Yeah, I think it's dangerous, number one, as a clinician, but especially as a layperson or the general public to understand and try to see what their symptoms are and evaluate them and say if they have a cold, a common cold, or if they have coronavirus, COVID-19. I think that's very dangerous. Most clinicians would not do that. Certainly there are some things that may be more, have a more predominance for certain illnesses, but I think if you are, again, these are all viruses, whether it's the common cold virus, rhinovirus, whether it's the common cough and cold coronavirus, whether it's influenza, whether it's SARS-CoV-2, they're all viruses. They all have similar ways of presenting. So I think if there's any question, the first thing you really need to do is go out and get a test if you can get a test.
And Taylor, I'll just say the answer to your question is this. There is absolutely no way, based on symptoms, that you can distinguish between a common cold, Omicron, and Delta. Now, we'd like to, and people can give you odds about it, and you can hear all the experts say, well, I can do this. No, you can't. Because we've seen people with coronavirus or COVID presenting with diarrhea. We've seen people with COVID presenting with loss of sense of taste or smell. We've seen people with COVID presenting with nasal congestion, sore throat, runny nose, cough, fever. Well, wait, that's what we all get when we have a cold. So how is that any different? The reality is you can't distinguish, and that's the weakness. And because that's the weakness, we have to figure out how to prevent it. So, Hawkeye, yesterday the CDC says we're going to pivot and we're going to say if you're asymptomatic after testing positive or having been exposed after 5 days, you can go back to work. But you absolutely mandatory must have a mask on.
Yeah, and I think people really need to start and understand and look at those details of what they said. They said if you test positive and you're asymptomatic, you can go back at 5 days. It doesn't mean if you start having symptoms and you test positive that it's necessarily 5 days.
That's not what it says.
So it gets you, it really is getting to understand what people are going to hear is if I have it, I can be 5 days and I can go back out into society. It is important, just as you said, to continue to wear the mask and understand if you test positive, maybe because you were exposed, you have to stay home for those 5 days. If you develop symptoms in those 5 days, although it didn't necessarily say, it does say if you have a fever, you have to continue to be home until after your fever, but there are specific details in that guidance that they gave.
Yeah, I think the key is that what the CDC really did was they recognized that there is a shortage of essential workers and healthcare workers, and so they adjusted the guidelines to help address this shortage, because otherwise you're not going to have food in the shelves, you won't be able to get healthcare, and you still may not be able to get healthcare. There's still a significant supply chain shortage, and we can talk about that all day long. But the reality is they responded to that, and they responded to it by saying, okay, look, Omicron probably has a shorter symptomatic, shorter transmissibility period, and we're heading towards Omicron. So what we're really going to say is after 5 days, you can go back to work if you're asymptomatic, but you have to have a mask on. And what they're really saying is that masking prevents transmission as the amount of, or the degree of transmissibility begins to wane at 5 days, the mask can prevent it. That's really what they're saying, and therefore you can go back to work. But they're really focusing on essential workers and healthcare workers to keep the doors open.
And
Taylor, I'm sorry, go ahead.
I'm sorry, and I'd still add to that too. You know, I think it does get very difficult because really in symptoms they just mentioned fever. So I think if you are testing and you are positive, and then at day 4 while you're home you start to develop cough or sore throat or any of those symptoms, aches, you are starting now to become symptomatic, I would probably advise staying home at least another 3 days or 4 days.
Well, and here's the answer too, remember. Again, they're not saying that you can't spread the disease.
Yeah.
What they're saying is that a mask prevents spreading of the disease when your infectivity is less.
Yeah.
That's what they're saying. And it doesn't say don't wear it. It says you have to wear a mask if you go back to work. Okay, Taylor, that was a really long-winded answer, but look, the real short take-home message is symptoms alone cannot distinguish. Let me repeat that. They cannot distinguish between the common cold, Omicron, Delta, or the original variant, and therefore the advice has to be the same if you start getting those colds, those symptoms. That's what they say to you. Test, stay home for 5 days, wear a mask for the next 5 days. Okay, Taylor, do we answer your question there at the end finally?
Yeah, I was going to come back, but you wrapped it up there at the end, so I'm glad you drilled down. And I do have a follow-up just based on your answer about testing, because we had a story this morning on our newscast about reports suggesting that those at-home tests, certain ones of them, are not as great at detecting Omicron because of the sensitivity to them. Have you read the same kind of thing, and what's the best advice on at-home tests right now with Omicron?
Oh, that's a great question. And we are blessed today because Dr. Rachel Eastman, the director of microbiology lab, is right here. She has been steadfast with us throughout this entire crisis, and the best news is this is her area of expertise. So, Rachel.
Yeah, so that data came out of the RADx program, which is an NIH program that stands for the Rapid Acceleration of Diagnostics. They've done a great job pairing with the FDA to do continuous evaluation, both of our antigen tests and our PCR. So a lot of the data that we have early on how all of our testing responds to these new variants is coming out of that group. And the FDA put out just a summary with no attached data that suggested that the sensitivity of the rapid antigen tests, those over-the-counter antigen tests, is decreased with Omicron. Now, I'll tell you anecdotally, we've been hearing about this for a week, 10 days, maybe 2 weeks or so. So we've heard about patients that were symptomatic. They took an over-the-counter rapid test. It was negative. They were still symptomatic. They took another one. They finally got a PCR, and the PCR was positive. And so it tracks a little bit with what we have heard anecdotally. I think we still have more data to gather and to understand in more clinical trial type of situations, how well do they perform? But it is really disappointing because we need all of the tools in the toolbox for this winter, and so having a decreased sensitivity of those antigen tests, I think, is going to be a challenge. What do we do about it? I think that if you have symptoms that are consistent with COVID, which is a broad range of symptoms, and you have a rapid antigen test, definitely take that test. If it's positive, that gives you a lot of information. Quarantine and appropriately report that to your healthcare provider so we can count those numbers. If it's negative, I would really encourage folks to go and get a PCR, because it could be falsely negative, or you could have a different virus. And we really want to make sure that we understand if that's a false negative or a true negative, and that's only going to be done by seeking out a PCR test performed in a laboratory.
One thing we know is it's getting harder to get to those tests in labs because there's an overwhelming number of those being performed, and we're trying to get our own employees tested. And so we're trying to find ways to open up and reopen another swab clinic, as are other hospitals around the country. You can also see it happening. Even the drugstores or the CVS, Walgreens of the world are getting overwhelmed by vaccination, the number of tests, and people wanting to be tested. So it's getting harder to get a test there, Dr. Lisa.
Yeah, I mean, it's hard to get a hold of the antigen tests. The antigen tests are expensive, and so that's a challenge. Yeah. It's hard to get a PCR these days. The laboratories are as overwhelmed as the rest of the healthcare workers. You talked a little bit about staffing of beds. We're struggling to staff our laboratories, and that is a nationwide shortage of the medical laboratory technologists. These are the folks that do all of the testing for us. They are board certified, well-trained, hardworking folks. They have been running this COVID marathon for nearly 2 years now, and we're really struggling with staffing there, and we'll continue to struggle for the duration of the winter. I think what you're going to see, and what we've already started to see, is it's difficult to get a test appointment. We're going to see delays in turnaround time. We've already seen that nationwide. We've experienced some delays in our laboratory, and we're trying to work through that. But it's going to be a challenging time to get a test, which is going to make it very difficult for this particular Omicron wave.
Taylor, did that help your question?
Yes, it does. Thank you.
Any other questions out there? All right, so we've already kind of dove into this conversation a little bit, and Hawkeye, any other reflections you have about where we are in the crisis, and what is your crystal ball saying to you? My crystal ball's ugly.
I think it's going to be that repetitive message that we have been saying. This is going to continue to be the pandemic of two populations, and we've heard people comment on us saying that, but it truly is. It is the vaccinated versus the unvaccinated. And there were two very good articles now that have come out that have shown that those booster doses of mRNA vaccine are able to induce potent and good levels of neutralizing antibody to Omicron. So even though the mRNA vaccines are the wild type or the original ancestral Wuhan spike, there are two different publications in two different journals, peer-reviewed, that do show that if you get that third dose, that booster dose, you are going to have an increase or a boost, or actually now detectable neutralizing antibodies to Omicron. So again, another miracle of science and medicine are these mRNA vaccines. So if you have been vaccinated and you are due for your booster, please go get your booster. What we are going to continue to see is those people that are unvaccinated, because in those same papers, they show that even people who had been infected previously have no neutralizing antibody to Omicron. So those people who are not vaccinated and boosted are going to continue to have higher chances, higher risk of going to the hospital, higher risk of dying, higher risk of those other complications as well. And I think that is, the main message here at this point.
Well, and I think let's do a little analysis too, just to sit back and say that the data coming from South Africa, Europe, and the United States says that hospitalizations between 40 and 70% less likely with Omicron. Yeah. The problem is that, in Kansas City, let's be clear, that at most right now, we're probably 50% Delta, 50% Omicron. Yeah. At most, we're 50% Omicron. That means over half of the people out there getting COVID-19 are still the Delta variant and at high risk for hospitalization. So let's just put that out on the table. Don't get so darn confident and cocky about this being Omicron. Second, this thing about, oh, my cold. Oh, that's cocky too, because it's wrong. Yeah. It doesn't say you're not going to be hospitalized. If people have a common cold, what's the risk of hospitalization? It's virtually zero, unless you have really severe underlying diseases and you're one of those folks that walk a tightrope every day. But it's really a small chance, right? Now let's step back and say Omicron. Okay, well, Omicron, let's say it's 50% less likely than Delta. But it's 2 to 4 times more infectious than Delta. Yeah. And if you look at that curve, can we show that national curve again for just a second, guys? So if we can look back at that national curve from that shows the straight up line about the rate of infections right now rising in the United States, look at that for just a minute. It's a straight up line. It's as high as it has ever been, and it's still going straight up. We're going to have far more people infected with Omicron and thus with COVID-19 than at any point in that pandemic. So even if you're 50% less likely, if you got twice as many people, it's the same number of folks flooding hospitals.
Yeah,
and I think that's what we have to be afraid of.
Yeah,
and that's by the way, that's what the South African data actually says. It doesn't say that hospitalizations went down. It says it didn't go up as much as they expected.
Yeah, I'd like to interject. After your statements, you're always saying less than Delta. But if you remember Delta, the best numbers I remember had a 50% to more than to a 200 times chance, or a 2.5% higher, or multiple 2.5 times higher chance of going to the hospital than all of the other variants as well. So we are comparing Omicron to Delta, not the original Wuhan.
And if we compared Omicron to the original strain, we'd say
about the same, probably.
Well, maybe the same, maybe more infectious.
And we know how, especially pre-vaccine, how much morbidity, how much mortality there was with coronavirus at that point.
So Dr. Jessica Calendar-Rich is with us today. She's one of our outstanding geriatricians. Actually, she really heads up a lot of our geriatrics programs, especially in the nursing homes. Jessica, or Dr. Calendar-Rich, how are things going out in the community, in our nursing home community? What do you see coming for our elderly that are in nursing homes?
So we have really been seeing little small outbreaks kind of all over in many nursing homes all around the community and around the country, which is pretty expected given the rate of rising, as you've already shared, cases in the community. And we know that the cases in the nursing home follow that. We are seeing, thankfully, far fewer people end up hospitalized or dying. However, there's a distinct difference between those that are fully vaccinated and boosted compared to those that are not fully vaccinated, and even compared to those that are not boosted. So we're seeing the case numbers are much lower for those that are vaccinated, and the hospitalizations are lower. They are still definitely happening. A third of the clusters of outbreaks in the state right now are long-term care out of all of them, and they're more than a third of the cases really statewide. So what's interesting is that the vaccination rates are great, right? If residents, I'm talking of the people that live in nursing facilities, they're more than 80%, but the booster rates are pretty low. Locally, there's 60% of those folks that had been vaccinated are boosted, and it's a little bit lower than that nationally. So we're sort of holding our breath and waiting to see what comes of this.
Yeah, I'm holding my breath, and I'm not liking what I'm feeling, because especially in the nursing home pipe, if 1 in 100 Americans over 65 have died of COVID-19, okay, that's an ouch, right? I mean, that's a gut punch. But if we then say that, which remember, because some people have said, well, these people are going to die anyway, which to me is that's just brutal. I mean, to say that out loud is just brutal. But then the second thought is that the average life expectancy in America has dropped, so they weren't going to die right away anyway, as they have. So let's take that idea off the table. It's not, Omicron isn't just, some of the things that you hear being made up out there, they just hurt your heart. Mm-hmm. And when you look at how vulnerable folks are as they get older with multiple health problems, and whether they live in nursing homes or they're at home, they are going to be the folks who struggle the most with Omicron, because their immune systems may not have the same memory. They may not have the same ability to respond back. And so Omicron can be especially a threat.
Right. I mean, even, data that came out in the last month showed that only of all of the nursing facility residents or older adults, anyone over 65 that received fully vaccination, 69% of them had no evidence of antibodies at that 6-month peak. And so we really, really have to get these folks boosted.
Yeah, it is a struggle. So Dr. Calendar, what can we do with nursing homes? And what's going on around visitation? And are folks trying to clamp down on things as far as visitation in nursing homes to help prevent the spread of this?
Yeah, so I think we can all remember way back in March of 2020 when everything shut down, and for nursing facilities, visitation shut down really tightly for many months, in fact, almost a year, and really just started opening back in March of this year. It's been really interesting to watch because initially there was CMS, or Centers for Medicare and Medicaid, were opening things up pretty slowly in the nursing facility world until back in November, a month ago, when a new regulation came out that said that nursing facilities cannot restrict visitation except in really dire circumstances that will almost never happen, which means that we really have to rely on visitors to be really smart about when they're coming into the building. And we have to rely on them to not come when they're sick and not come when they're exposed, and hopefully get vaccinated. Because there's nothing that the facility now cannot stand there and other than screen a visitor, they actually can't prevent them from visiting. And frankly, the isolation has been terrible for people that were stuck in facilities and couldn't see their families. Opening the doors to anyone without any restrictions also has the potential to be terrible in very different ways. And so I think we really are just begging people in it not to come visit their loved ones when they're sick or exposed, and to be really wise about how we engage with people and still do all those things that we were doing before with masking and distancing when possible.
Yeah, gosh. And are your staff staying safe? Are they all vaccinated?
I wish I could say yes. The 2-shot regimen, or the initial J&J vaccination rates in the state of Kansas are 76% for nursing facility staff, which is
not that great. It's good, but not great.
Right. Booster rates are 28%.
Oh, that's not good at all.
So we are really worried about staffing buildings. We are really worried about staffing bringing it in, and I think we're all just really worried. Yeah, we build the airplane while we fly it. Somebody told us that one time, JKR. I wonder who that could be. I'm not sure who that could have been.
Yeah, I don't know. So, Dr. Leisman, let's talk a little bit about wastewater testing, because I like to talk about it all the time. What a great topic, wastewater testing. But we've talked about it a lot as a way of helping forecast public health crises. Pretty good tool.
Yeah, what a cool program, right?
Yeah.
And pretty unique to the state of Missouri. Not every state is doing this type of work. This is a great collaboration between Mizzou and the Missouri Department of Natural Resources and Health and Human Services. We oftentimes, I think about SARS-CoV-2 as a respiratory virus. That's how it usually transmits. But we do know it's also shed both in stool and urine. And so pretty early on, there was this idea that we could use wastewater surveillance as a public health measure just to understand what's going on in the community. So initially, it was brought in to see, community prevalence. Was it really high? Was it really low? Can we focus on that? And then they expanded the program to start doing variant testing, and has given us some really interesting information about the spread of variants across the state of Missouri. So a very cool program, and a really nice website, a nice resource for folks if they haven't checked it out.
Good stuff. All right. So, and what's that website? If they want to go look at
I found it by Googling Missouri.
Water and stool, Missouri.
I think it's like the sewer waste variant or surveillance, waste surveillance program.
There's a Jayhawk Tiger joke in there somewhere, but we're just going to let it sit out there.
But I'm going to give Mizzou this one.
Yeah, M-I-Z, Z-O-U. That's good. Mm-hmm. All right. Jess, I bet there may be a couple of questions out there today.
There are, and the feed is filled up, Dr. Stites, with a lot of questions about masking protocols. Do cloth masks work with the Omicron variant? Do we need to be getting away from cloth and going back to do we do N95s or surgical masks? Just a bunch of questions. So can we just kind of go through any updated masking protocols?
Let's do some masking guideline stuff here, Hawk, because what we know is that, especially with Omicron, it looks like the cloth masks may not be as protective, and you're probably better off if you can wear surgical masks or even higher grade masks than that, but they are still protective.
Yeah, I mean, we've seen some expert opinions and some opinions in the national media and other stories saying nobody can wear cloth masks anymore, everybody needs an N95. I don't necessarily agree with that. Again, remember, certainly droplets haven't changed in size. The virus, from what I understand, hasn't changed its property. It's not any smaller than it was before. We know that the CDC guidance on masks has not changed as of yet. We know that 2 to 3 layer cloth masks don't filter as well as, say, a surgical mask, which doesn't filter as well as an N95. However, the important thing there is also to remember that in that guidance for mask wearing, it is emphasized that the fit needs to be good. So the fit around the nose, the sides, and the chin needs to be optimal, and that will help reduce expression of virus and droplets out into the environment and help your inhalation as well. We've seen people who've also said, well, you can just go to the pharmacy or a hen house and buy a box of surgical masks. I haven't seen any data to suggest that those surgical masks are validated and vetted just as those surgical masks in the hospital are. So that's the other thing you have to understand. I would still encourage people to wear what they can. If they wanted to double mask, the best data and the guidance on CDC continues to be a surgical mask and then a cloth mask over that. That is certainly reasonable. If you wanted to go out and, say, buy a KN95, that's reasonable as well. But right now, there is no change in guidance at this point. Understand that the fit has to be good, and I would rather see you wearing something when you're out and in public in those high-risk situations than nothing at all.
Yeah, something is better than nothing. I think surgical masks are better than cloth masks.
Yeah.
K95 are better than a surgical mask, and an N95 is the best layer, but you have to have fit tested to really know.
Yeah.
And most people are going to do fit testing. So,
and remember, in the hospital, too, we have different levels of those surgical masks.
Yeah,
and so I think that's the important thing. Every surgical mask is not the same.
So at the end of the day, Dr. Leisman, what are your thoughts? You're a doctorate of microbiology. What thoughts about the masking?
I don't. I think that Omicron is such a new virus that we still have a lot to learn. This variant emerged around Thanksgiving. We've known it existed for 5 weeks. So I think everything that Dana said is accurate and is the best information we have at this time, and we have to move forward with that. But some acknowledgement that we still have a lot to learn about how this virus transmits, what it's doing in the upper respiratory tract, and as we get more data, we may have to pivot on what we tell folks and what the recommendations are. And I think that flexibility is sometimes frustrating. People want a single message and to not deviate, but it really is a very new virus. We have a lot to learn, and so keeping that in mind as some of the public health recommendations maybe change over the next 4 or 6 weeks, I think will be important.
Yeah, it does. I bet where we're going to land is that, and again, not all cloth masks are created equally either. That single layer cloth mask probably doesn't do a lot. Double layer cloth masks probably help. Yeah. Triple layer cloth masks help more. Surgical masks are better. And at the end of the day, you do what you can. And what I would encourage our listening audience or viewing audience to know is that we recognize that it's more expensive to go get a bunch of surgical masks, right? And you have to keep replenishing those where you can wash your cloth masks. And sometimes that's what you can do. And you know what? That's still better than nothing. There's no question that a cloth mask is still better than nothing. If it helps preventing you from giving something to somebody else, as well as the ability of you to inhale something. The problem with Omicron and the problem with coronavirus in general is, to borrow a Star Trek reference, gentlemen, live long and prosper, they are shapeshifters, meaning they'll change their shapes. And the reason that's important is they can change rapidly. That's the mutation. That's why we keep having all these darn different variants, is that coronavirus is a shapeshifter. And so it keeps changing the story on us. We keep trying to change up. And your point earlier, Hawk, I think is dead on right. It is nothing short of miraculous that the vaccinations, especially the mRNA vaccinations, work this well against so many different variants. That is really impressive in terms of the outcome of this vaccination program.
Yeah, and remember, it's those B cells and antibodies, as we talked about. We certainly want a boost in antibodies when we can to help prevent infection and help treat that early infection if you do get it. but it's also those T cells that come in and really provide that protection against the hospitalization and severe disease.
Yeah, don't be afraid of getting your booster. I know a lot of people have had some resignation. Oh, I had this side effect, I
Yeah.
had that side effect, but the answer is the Omicron is the worst side effect. Jess.
Michael wants to know, with the situation as dire as you are presenting it, the need for antiviral medication is more important than ever. So where is the urgency for Operation Warp Speed for antivirals?
Well, I think there is a lot of urgency, and there's great drugs coming out. I mean, molnupiravir, the one from Merck, is okay. The one from Pfizer, Paxlovid, that's a freaking grand slam home run. That's the kind of thing that can help make this pandemic turn it into a much more manageable story. That plus some of the drugs coming out from AstraZeneca with the antibodies for people who are really immunosuppressed, and even strovimab and the other drugs.
Yeah.
But I'm really, you know, and you and I have had this conversation. I'm really encouraged by the data around Paxlovid. We hope the virus doesn't gain resistance to it, because an 85% to 89% drop in hospitalizations amongst the unvaccinated, that's remarkable. And it looks like it's going to stay that effective against Omicron, also remarkable. So there are drugs coming to market, but you have to realize, to our audience, these things are hard to develop. You don't just happen overnight. Paxlovid, to us in medicine, feels like it came out overnight. That is so remarkable. But historically, just to get a new antibiotic would take decades. So to think that this new antiviral could come out that fast that's a big story.
Yeah, I would agree. I would just kind of ask what exactly is meant by the word or the phrase. There's a lack of urgency, or there isn't urgency, because I think there has been, and we know that development of drugs takes years, takes resources, takes trials to make sure, number one, that it's safe, number two, that it's effective, not just in the laboratory, but in humans especially. And so I think that there has been urgency, but I think you're also talking about scaling up production for the hundreds of thousands or millions of doses that are needed. I think that's the other issue as well. And so we know that the data there, the trial data is there, the safety, the effectiveness so far in that trial data is there. Now it's a matter of also scaling up that production so that we can get it into those pharmacies and get it to those people who need it, and that takes time as well.
And they don't do it until they've got the final trial results and make sure there are no side effects. Otherwise, drug companies would always spend, and I don't speak for pharma, but and I'm not a speaker on any pharmacy bureaus, but I'll say, Pfizer's done a really good job of being very transparent with their information. And then they talked about the data around their vaccination. They were out in front with it. They led with it. They put it all out there for everybody to see. They've done the same thing with Paxlovid. Kudos to them for that. And I think that what you know when you are in the inside of that world, what you know is that it is incredibly expensive to bring a drug to market. They can't start building all the manufacturing facilities to run at top speed until they know they're an authorized drug. And I think what Pfizer ended up doing is they looked so good, they stopped the trial on an interim basis. So they didn't continue because the data looked too good. It was felt to be unethical to continue. So then I think Pfizer started getting ready to ramp up. But they had to get that final seal of approval from the FDA. So they don't really expect to be at full capacity with Paxlovid until March or April.
So Dr. Stites, just to follow up to that, are you saying that it takes longer to create the medication than it does the vaccine?
No, it just takes a long time to do both. I mean, and remember, vaccines are medication. And so it just takes a long time to get these drugs ready to be out to market and to be, and again, you can't invest millions and millions and millions of dollars into facilities to produce something and then not have it be approved. So the length is really, they know the drugs, they know that they're good because of the trial results, so they start ramping up, and then they get the thing from the FDA, and then the FDA has to go inspect all these facilities to make sure they've maintained the same rigors and the same standards. That's one of the things that hung up the J&J vaccine for so long. If you remember back to earlier in the crisis, the FDA went to some of the drug manufacturing sites and said, I'm not sure this is right yet. And so that's all there to help protect the public.
Yeah, and I think there's just different complexities with each, certainly for antiviral medicines in general, we have seen that it takes time to develop those. And so I think even what we have seen so far with at least these two new drugs to come to market now, not old drugs that are on the market and have been repurposed, but really new drugs that are coming to market for this, I think is with urgency, and it is a short period of time.
Kathy has a question for Dr. Leisman. When administering a home test which results in a negative reading, but then you continue to have symptoms, what are your thoughts about taking a second home test, maybe of a different brand, to confirm that it really is negative?
Yeah, I think it's a reasonable thing to do, but I would still get that PCR. If you're symptomatic, the sensitivity of the home tests is just insufficient, in my opinion, to treat that as not COVID. So taking another home test is a reasonable thing to do, but I would still work on getting that PCR appointment scheduled and trying to get that final test done, because ultimately you're going to need that high sensitivity molecular test to feel good about that negative.
And just to say, you may have you can have another virus. So it's not all Omicron, it's not all Delta, it's not all COVID. It's, there's actually more rhinovirus out in the community than there is some of this other stuff. But the problem is we don't talk about it, and we don't talk about it because it's not severe and you don't get hospitalized with it. So still a lot of it.
That sinking fear as well is that when people will take a test and maybe it'll be negative, or they won't take a test, and they're still going to use these antiviral drugs, and so that's the other thing to consider.
Yeah, just say
too,
no
but
to that. That's a bad idea.
Dr. Stites, there's a few questions about kids and vaccines, and I know we're going to have Children's Mercy on next week, but I wanted to just see if you could help with this, because I know that with kids being out of school, this is a good time to get them vaccinated. But Christy is asking, where can she point people for the data that shows that kids who have had Delta still need to get vaccinated because they are not protected against Omicron?
Well, Hawkeye, I think that let's be careful with the answer to this question, because that's
Yeah.
Let's piece through that a little bit.
Yeah. So I'm not as up to date on the pediatric data, but we do know that adults who've had previous infection, number one, don't have the same amount of neutralizing antibodies as those who've been vaccinated do. The booster helps boost all that. I talked about that earlier in the show. But we also know that reinfection can occur and does occur. And we also know that, just as you said, children's hospitalization rates are going up in general. And so I think those are the important things to know.
Yeah, and I would just say I think that the question is actually very layered, because it depends on how long it's been since you've had COVID-19. It depends on when your child's had COVID-19. It depends on the age range, because the data will look different in different age ranges, because we know in the 2 to 6 months, the 2-year-old range, it didn't look as good with the Pfizer vaccine. The 2 to 5 looked really good, and the 5 to 12 looked really good, and the 12 to 16 or 18 all look really good. And so the idea that if you've had COVID-19, do you maintain protection? The problem is that Omicron's different, and so it may be able to evade your immune system if you've even, and we saw that in the South African data, that even if you've been, and they had a 70% prior infection rate with COVID-19 of one of the other variants, and yet people were still getting getting Omicron. So, and because hospitalization rates are rising in children with Omicron, I think I would be very careful with the idea, and there are far more unvaccinated kids than there are adults right now. And so I think I'd be really careful with any ideas that you don't need.
And we do know, I think there was a MMWR report out of Kentucky maybe, showing that people who were previously infected and not vaccinated did have the higher risk of getting infected again, or reinfection with a different virus. They were looking at particularly the Delta period of time. So you had a higher risk of getting infected with Delta if you were previously infected and not vaccinated than if you were vaccinated. So that came out over the summer as well. I would have to believe that same logic and that same conclusion holds true with Omicron variant, just because the spike is so different. It has been shown to be, say, more fit or bind stronger and easier to the receptors. So what that translates to is people say it's more contagious. So I would say that same line of thinking holds true.
Dr. Stites, a couple more
Yes, ma'am.
questions?
Please, let's do it. We got to
okay,
get some. I bet there's some questions out there for JKR too.
There are, and I think this will be a good one for her. Maria's asking, can you talk about the nursing shortage in all areas of healthcare, why it's happening, how it's affecting everyone? Marie feels like this is a part of the crisis that people aren't taking as seriously.
Yeah, I'm going to let me jump on that first. So absolutely, that's really one of the biggest challenges we have in staffing hospitals. Our census is high, but we have more beds. Everybody has more beds. The question is, do you have the staff to take care of this? And what we see is that two major forces. Delta and Omicron are incredibly transmissible. Let's not forget that. They're both incredibly transmissible. And so our staff are getting sick. And, our staff is human, and everybody's tired of wearing a mask, and everybody's tired of not being able to get together, et cetera. And so The reality is that we jumped from like 170 to 300 people out yesterday, either with infection or with having to quarantine. And so, that's a big number, folks. And unfortunately, we're afraid that number is going to grow. And that's true throughout the Metroplex. In our CMO call yesterday, the number one problem we have in keeping hospital beds open is staff. And the biggest issue for us is nursing staff. And the challenge is this. We normally staff at a 3 or 4 to 1 ratio. If you go to a 6 or 8 to 1 ratio, that's just hard on our teams, right? They still want to give you the same high quality care you always get. And that's true in all of the hospitals in the United States and Kansas City, everywhere. But it's just becomes physically difficult once you get, if you get 6 or 8 patients trying to deliver the same care you can when you have a 4 to 1 ratio. So and then you have to say, okay, well, how many beds can we really staff before we keep open, before we run through our staff, or we so exhaust them? The second issue is that people have left healthcare. And they've left healthcare because at first they were sort of heroes, but now people villainize folks in healthcare because they're trying to talk about COVID and tell them things they don't want to hear. Well, that's just discouraging. And I think folks are making the decision to leave healthcare for different jobs that aren't so stressful, where you're not seeing so many young people dying from a disease that should have been preventable. So I think it's a twofold thing, right? It's a double whammy. A, it's infection, and B, it's flight. People are leaving. Jessica Calendar-Rich, how's that in the nursing home community?
I mean, we are seeing exactly the same thing that you're describing. It's nurses, it's aides, it's really everyone at every level, I think, in healthcare that is both tired and getting exposed or getting COVID themselves. And so, I think everyone is struggling. The one challenge we're seeing that we hadn't seen before in that world is that people that were historically working in nursing facilities are now sometimes being pulled into the hospitals to work, which is really important, and the hospitals need that staffing also. But unfortunately, it creates a vacuum at another community settings where we also need those really important healthcare providers to be present.
And Dr. Calendar-Rich, one of the challenges, I think, is, and correct me if I'm wrong, but one of the primary sources of admissions for nursing homes is a hospital, right? Mm. So if we can't transfer patients out of the hospital to the nursing homes because you don't have staff, that just means we can't get people into the hospital who are sick and need us. So it becomes this really difficult story, and it comes down to one thing, which is we don't have the staff to do it. So what's the response of people out in the public need to be? You got to try to stay safe. You stay safe not only for yourself, but for everybody you care about. And how do you stay safe? Unfortunately, the rules, we know the rules, right? And the rules are great rules. They're hard to live by. I get it. They're hard to live by because everybody's tired of masking and distancing. But the reality is, at the height of this crisis, we bent the curve. And now we are being challenged to bend it again before it bends us. Because I'll tell you, you don't want the bends. Jess.
Okay. So Faith has a question, and we've been getting a few about monoclonal antibodies, but just help clear this up because we get this question a lot. But why aren't monoclonal antibodies more easily accessible? The wait time for someone to get in for one takes a while. So by that time, it may be too late for the antibodies to do what they're intended to do. It's not just that simple.
You bet. Hawkeye, there's not enough beds, and there's not enough antibodies.
Yeah, I think supply is a large issue in giving monoclonal antibodies. Also, things like the institutional engineering, the spots where people can do it, it does take some amount of time. So it's a amount of getting, again, those people to staff those areas so that you can get those antibodies in an efficient amount of time and in the proper way. Those are issues. But now also what we're seeing is some of those monoclonal antibodies do not have good activity towards Omicron, so that will actually make the supply less as well. So there are a number of factors there, but there are certainly, it's not as easy as just going to a pharmacy with a prescription, getting that and taking that home. There are system issues there, but also the supply is another big thing.
So a question for Dr. Calendar-Rich from Becky is the nursing home situation better or worse than when we first saw the pandemic? Or what's better or what's worse about it? And what things should someone keep in mind if they're needing to put their parent in a long-term facility?
So overall, I'll say it's better. It's better because we have way more knowledge and we have a way better understanding of what's happening and how to prevent it and what to do if COVID should come into the building. So overall, it's much better. There are always things that can be improved. And I think that we're going to watch how this spike plays out really in the community and in the nursing facilities. But I also think that nursing facilities now have the tools that they need. They actually have tests. They have access to PCR and to antigen tests. They have access to PPE. They have backup plans for those things at the state level. There are new options being rolled out, thankfully not yet here in Kansas, but in other cities that have, or other states rather, that have pulled in the National Guard if staffing shortages have gotten that bad. There are plans. And I think that even having a playbook of what to do puts us millions of miles ahead of where we were a year and a half ago.
You had something to...
Yeah, and I'd also like to go back to that first answer about the monoclonal antibodies. You know, there was a time when we weren't giving any monoclonal antibodies out because nobody was coming in for them. So the other thing with supply is now the demand is so high. But there were weeks that we didn't give any. So it's supply, it's demand, it's system issues, all that kind of stuff.
Just time for one more.
So Stephanie wants to know, who and where do you go and how can you donate antibodies? Also, can a vaccinated person who had COVID donate?
Okay, great question. Convalescent serum, which we don't use as much, although sometimes in extremis, and sometimes especially in third world countries.
Yeah, the data for that has been really mixed. Most of it showing no benefit. There are some studies that show high titer, meaning high amounts of antibodies within that plasma, does provide some improvement, but I think most of that is in hospitalized patients. It's not used in the outpatient setting, but overall the benefits from that have really not borne out to be as favorable or with a high percentage of favorability as those monoclonal antibodies. And right now I don't believe that there are any blood centers or anything accepting those high titer antibodies or plasma from people who've been vaccinated.
Yeah. So let's go around the horn and get final thoughts from our guests. Dr. Leisman, I'm going to start with you. Thanks again for being on our program. You guys don't know this, but she works like 100+ hours a week and keeps our lab running on time in the micro lab, and we're very fortunate to have her. So.
Yeah, well, this has been an uplifting discussion, and I'm going to add a little bit of insult to injury here, but we're going to have flu this year. And I think that that's going to further stress our laboratory and our hospital. We saw flu emerge in early December, circulating in the community. We're running about 2 to 6% positivity. Most of it's H3N2, which tends to be a bit more of a severe flu year than other years. So I think that all of the precautions that we are asking folks to take to prevent SARS-CoV-2 infections are also going to help us bend the curve a little bit on influenza, which is going to be really important. So masking helped last year, washing your hands, get your flu vaccine in addition to your COVID vaccine, because that's going to be an additional stressor, I think, this winter. And so otherwise, vaccinate, boost, be safe for New Year's.
Yeah, stay safe out there.
Yeah.
Dr. Jessica Calendar-Rich, final thoughts for today.
I want to say thank you to all of the healthcare workers that are out there. We are all stressed and we are all struggling and we are all making it. And to everyone else out there who's doing all the right things, thank you, because we really, really, really have to protect all of the people around us and ourselves, both with masking, vaccines, the whole thing. And I really do think we have the ability to be in a better place as we move forward if we can all work together.
Yeah, I think we do. And thanks for your great service out there in our nursing home and elderly community. I don't know what we would do without you, so thank you. Hawkeye.
It continues to be the same message. Vaccines work. The booster works. We are getting now good data to support the fact that it does continue to help reduce hospitalizations if you've gotten that booster. So please, if you haven't gotten vaccinated, know people who haven't gotten vaccinated, go encourage them to get vaccinated. Start now. Start whenever you can. If you are eligible for that booster, go get that booster. Again, a miracle of modern science and medicine these vaccines have been. We know they protect you. We know they're safe, even against Omicron. And we talked about this yesterday, Steve. Although the data, there are probably some caveats and limitations to this data. For the week ending on December 27th, we know that via covariates.org, only 8% of the variants of the sequences that were sampled in Kansas were Omicron, and the rest continue to be Delta, just as you said. The majority of infections probably still continue to be Delta. We know vaccines work against Delta. We know the vaccines work against Omicron, so please go get vaccinated.
And then we talk a little bit about next week, then I have some final thoughts. First of all, obviously, thanks for being with us today. Tomorrow, we have another encore presentation for you, but coming up on Monday, we introduce you to a couple expecting a baby. We'll be back live in the studio again every day after that. But things took a bad turn for this couple when they both contracted COVID. One ended up on a ventilator fighting for their life. Neither were vaccinated. Did this experience change their mind about the vaccine? We'll ask them Monday when they join us live. Here's the thought. You know, from the start of this pandemic, we have stressed that we don't jack with the truth. We're not flapjackers. We don't flap our arms to jack with the truth, and we continue to follow that principle. The second thing we've tried to do is just be honest and tell you the truth, and we continue to follow that principle. We've also told you that that the way to stay safe is to follow the rules of infection control because they travel with you wherever you go. We stay true to that principle. We've tried to honor the folks and the great work that our folks out here in healthcare have done every day with the nurses and the respiratory therapists and all the frontline workers and all the essential workers and all the police and all the fire department. You know what? We stay true to that principle. We all want this thing to end. We've stayed true to that principle.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.